Thank you so much. Thank you so much for the opportunity to talk about STI prevention. And my focus is primarily going to be on the HIV prevention arena. And I really hope through this presentation you'll be convinced, if you're not already convinced, of the importance of STI prevention in the context of HIV prevention. I know for many of you it's very overwhelming to think about STI prevention when you're very busy with your HIV prevention approaches. And hopefully through this talk you'll see a more simplified approach that can be tailored for different settings and different populations. And I want to remind you that Dr. Papan earlier today said that to reach our goals to end infection, we need to enhance prevention strategies. And I think STI prevention, improving our STI prevention strategies is one way to do that. This presentation comes on the heels of a perspective piece by Jeannie Marazzo and colleagues that I think is very important. And the article begs us to consider STIs and the implications for HIV control. She reminds us of the good thing that modeling suggests that frequent STI screening among MSM and transgender women in the setting of PrEP for HIV prevention might over time drive down STIs, especially, certainly if they're linked to treatment. And one question she asks, which is very important, is the high incidence of STI going to undermine PrEP and treatment as prevention in the long term? I hope not. For this presentation, I'm aware of the time getting late, and I will provide a background on STIs and HIV, which I think is very important for the context of STI prevention in this arena. And I'll focus on syphilis, because certainly for our key population, syphilis is probably the backbone STI we need to consider. I'll talk about the importance of screening connection to treatment in our CELOM community clinic experience, and an idea of a service delivery model for STI that might be somewhat tailored to different settings. So actually I do have a few audience questions, and maybe we can get more than 6 responses to these questions. These are to test your STI knowledge. And so I'd like to ask you for the first question, for persons that have HIV, Neisseria gonorrhea uricus will decrease HIV viral load in the blood, increase HIV viral shedding in the mucosa, neither decreases or increases HIV, there's a typo there, or unsure. So I'd like to ask for your response. Okay, very good. I think we have some good understanding of the urethritis and what happens with HIV shedding. The correct answer is B. And for the next question, how long is the most infectious period of syphilis, early syphilis, if left untreated? So we're a little bit all over the place here. The actual correct answer is D, 3 months or longer. So the reminder is early syphilis is primary or secondary syphilis, and stages can last 4 months or longer. So the final question to test your STI knowledge is, genital ulcer disease increases HIV transmission up to 2-fold. Is this false, true, or you're unsure? It's a bit of a trick question. So is it false, is it true, or is it unsure? It's actually false. I said up to 2-fold. So the literature suggests 2 to 4-fold, and I'll talk about that in a little bit here. So I think it's really important to point back to the biology. What do we know about STI and HIV? And STIs do play a significant role in facilitating HIV transmission and acquisition. And we know this from a number of different studies. Studies of GUD, where there's noted increases of HIV transmission 2 to 4-fold. And as a reminder, GUD can be caused by syphilis, Haemophilus ducreyi, or herpes. And urethritis, you got this one right, urethritis due to Neisseria gonorrhea and chlamydia can increase HIV viral shedding, and interestingly, with treatment reduces HIV viral shedding. And systemic STIs such as syphilis can increase HIV viral load and decrease CD4 count, and treatment has been shown to reduce HIV viral load. Episodic herpes also can increase HIV viral load, and as we showed in Chiang Rai, along with other global settings, treatment of herpes with acyclovir can reduce viral shedding, HIV viral shedding. And it's also important to note that breaches in mucosa and inflammatory cells and mediators increase the risk of HIV acquisition. So this is a really nice study that was done by Kate Bush and CDC, and this shows that syphilis increases HIV viral load and syphilis treatment reduces HIV viral load. This actually is just a case example from this study. In this graph, you can see the titers, syphilis titers in the pink bar, and you can see the HIV viral load in red, and then treatment for syphilis with the arrows. And you can see there was a significant decline in HIV viral load after syphilis treatment. I think a really important issue is that STIs in numerous studies have been shown to predict HIV infection or new HIV infection. There's a previous study by Kyle Bernstein when he was in San Francisco, where he showed repeat rectal STIs increased or predicted HIV. This study also shows the same, that syphilis predicts HIV incidence among men and transgender women who were enrolled in a PrEP trial. And so it's important that STI screening and identification of STIs might actually really help us encourage and facilitate PrEP use. This study emphasizes the importance of PrEP in these at-risk men and women. So I'm going to spend a little bit of time, but I'll go through these slides more quickly because it is late. I'm going to spend a little bit more time on syphilis because syphilis, I think, is the backbone of the STIs we should consider in our key populations. As a reminder, it's acquired by direct contact, and it's a really important issue. Is 30% or probably more of individuals who are in contact with someone with early syphilis in the preceding 30 days will acquire infection. Infection can cross the placenta, and can infect the fetus and cause very devastating outcomes. And just a reminder of the stages of syphilis. Primary syphilis is classically a chancre, usually on the vulva or the penis, but actually in a lot of populations, chancres will be in the oral mucosa, in the rectum, and be hidden. And they are painless, so they might never be detected. Secondary syphilis is classically a disseminated rash and lymphadenopathy, and many systemic symptoms that often bring someone to care. This is the natural history of syphilis as a reminder: infection to primary syphilis, secondary syphilis, and latent syphilis, tertiary syphilis if left untreated. So as a reminder, syphilis diagnosis is really based on, in most settings now, non-treponemal and treponemal specific tests. These tests are cheap and accessible, and in fact there are point-of-care tests available. But diagnosis can also require information on clinical presentation, previous treatment history, and previous testing and titers. And confirmation of adequate treatment is really important with repeat testing and documentation of reductions in titer. So again, this is sort of a highlight of syphilis diagnostic tests. Direct detection methods are great, but not widely available. These include dark field microscopy and PCR, where you can detect treponeme on the mucosa in primary syphilis. And then this is a listing of different non-treponemal tests and treponemal tests. And a reminder about syphilis treatment. For the real mainstay for syphilis treatment is benzocaine penicillin injection. For the most part, that's one injection. For latent, it can be more than one injection. There's other alternatives, though, that are important to note. Doxycycline treatment can be used for treatment. It's been documented to have good serologic response in both HIV-infected and uninfected persons. Tetracycline, ceftriaxone, and azithromycin also can be used. But I'll admit, there are challenges for syphilis treatment. And some of these challenges include that there's been global benzocaine penicillin shortages, which make treatment somewhat challenging when the treatment of choice is not available. And around the world, in settings of Asia and South America, there have been concerns about penicillin allergy. I'd like to highlight a little bit about penicillin allergy. I think it's important to highlight some information we know. Although about 10% of persons report penicillin allergy, less than 1% actually truly have an IgE-mediated allergy, and even less with anaphylaxis. And this paper that's highlighted here actually it's less than 0.05% of the population. At CELOM, over the last 3 years, we've been using benzocaine penicillin for treatment of syphilis on site. And after more than 2,400 doses of penicillin, we've had no cases of acute reaction in anaphylaxis. Now, as we've heard today in different settings, we are having a global epidemic of syphilis. In the US, syphilis rates have doubled, primarily in men who have sex with men. And now we're seeing new increases recently in congenital syphilis. There's similar increases across the world in Asia, Europe, and Australia. And I'll point to a presentation tomorrow on syphilis and HIV, which will highlight some of these unusual presentations for syphilis. But both neurosyphilis and ocular syphilis has been documented. And these both can have devastating consequences. Now, bringing it back to our part of the world, Bangkok, I wanted to highlight the prevalence of various STIs in our Bangkok MSM cohort study, or BMCS. And as you can see, we had a number of STIs, herpes, syphilis, urethral chlamydia, and Neisseria gonorrhea of significant prevalences. So I wanted to kind of point back to STI screening in HIV prevention settings and what is recommended. Now, different settings, regions recommend different things, but STI screening and treatment is recommended in many settings for those with HIV, at least annually. And STI screening is also recommended as a part of PrEP provision. Most guidelines, at least at initiation and every 6 months, some guidelines every 3 months. But despite these screening recommendations, I think our screenings are suboptimal. In the United States, a recent study highlighted that even those HIV-infected persons in care are not getting completely screened. About 20 to 30% were not screened for various STIs. So I just want to go back to the HIV prevention toolbox. We have a number of really effective strategies. How did we go back? There. And I want to also frame a lot of what I'm talking about. It's it's framed within the approaches that we have available, including condoms and counseling. We have these great approaches: PrEP, treatment as prevention. And I want to highlight how screening and early treatment is also a very important part of the toolbox. So what are the benefits of STI screening and treatment for HIV prevention? So STI screening and treatment can reduce the likelihood of HIV acquisition and transmission, and of course it reduces STI transmission. STI screening and treatment can engage clients in their care, and I heard some mention of this around framing a sexual health or comprehensive health and prevention package. And certainly STI screening and treatment fits within that. I think our clients, the men in our clinic especially, want to have the screening and they want to have this information. It's an opportunity to reinforce prevention counseling, and STI might be a trigger to support behavior change or facilitate prevention approaches that weren't considered before. And it's also an opportunity to identify those at highest risk for biomedical HIV prevention approaches such as PrEP, as I highlighted earlier. And the final thing is supporting partner screening and treatment. Now, partner notification of an STI could bring a partner into the clinic or other setting for STI screening and HIV screening. So diagnosis of STIs needs to connect to treatment, and why? Now, certainly if the STI is diagnosed and treatment is not done soon, transmission can continue in the community. And I just want to remind you about what maybe our clients do on New Year's in Bangkok. And this is an example of a sexual network. And although many gay men and transgender women have sexual networks on the right here, simple networks with a few nodes, and every node is a partner. There can be more complex networks with many partners and different nodes connecting to each other. And this is just an example of how over time there's opportunities for new sexual partners, more sex, and potential transmission events. And as a reminder back to the statistics of transmission of infections, we use the reproductive rate, or the number of cases one case generates on average over the course of the infectious period in an otherwise an uninfected population, to help us understand transmission of infections in general and HIV infection. And this is influenced by a number of things, including the rate of the contacts, the probability of infection being transmitted during the contact, and the duration of infectiousness. And so certainly STIs can influence this through infectiousness. Time to treatment really does matter, just like it does for HIV. I've been hearing a lot about early treatment, same-day treatment, same-day PrEP. And early treatment of syphilis is important. I'd like to give two examples. One example is the time to treatment is 1 day, and then the time to treatment is 1 month. So if the time to treatment for an STI is 1 day, it has minimal, if any, impact on HIV transmission or STI transmission. You're arresting the infection, it's being treated. But if the time to treatment is 1 month, there's opportunity for transmission events, and there's also increased infectiousnness. So in 1 month, there might be 10 sex acts with 30% transmission of syphilis and 3 new syphilis cases. And if the person is HIV positive, there might be an HIV transmission up to 4-fold with sex acts. HIV negative, there may be the increased acquisition risk of HIV due to ulcerations or inflammation. So I'd like to highlight our Salem Community Clinic experience around treatment and treatment delays. And I think this will highlight the importance of timely treatment, and that referrals can mean treatment delays. Salem Community Clinic is in Bangkok, Thailand, and serves men who sex with men and transgender women for HIV testing, STI testing, and same-day treatment. And in Bangkok, the good news is we've had more PrEP availability and more in ART treatment. And this has meant increases in STI screening. But many settings aren't able to provide comprehensive STI service, and referrals have been coming from the community to Salem for treatment. So this is an example of our referrals for syphilis treatment over the last few years. We've seen over a 6-fold increase in STI treatment referrals, so men and women coming in specifically for syphilis treatment. Many of these coming in for treatment have high titers, and high titers can be indicative of early syphilis infection and also be more likely to be transmitted. At CELOM, we've noted 80% of those coming in with referral letters had a titer of 1 to 8. And this is an important slide on referrals for syphilis treatment and what it might mean for treatment delays. On the x-axis is the cumulative number of clients, and on the y-axis is the number of days from first screen treatment for syphilis. And you can see that most lie on that 0 line, 0 to 1, meaning that they're treated within 1 day. But you can see any of those above 1 day are treatment delays. The median treatment delay was 4 days. We saw persons that had delays 323 days and 20 plus days and hundreds of days. So just in summary, we're seeing an increase in this is reflective of the really great HIV prevention approaches that are available in the community. It's important that STI screening be connected to treatment. And it's really important that an STI service delivery model be used in the HIV prevention context. And I'll admit, I don't know exactly what this might mean for your setting, but I think it's important to consider, and I think it can be tailored for different settings. What does a service delivery model mean? It means inclusion of STI screening, diagnosis, treatment, and management in the HIV prevention activity. And it can be flexible and fluid to the environment, resources, population, priorities of the program. But most importantly, it's comprehensive. And so this is an example of what I might consider a service delivery model where screening, diagnosis, and treatment and management are all a part of the comprehensive care. For screening, in our key population, syphilis is the backbone for sure, but optimally Neisseria gonorrhea, chlamydia at sites of exposure, and viral hepatitis. I'm well aware that screening for chlamydia and gonorrhea is challenging with NATs that are expensive and delays in diagnosis. Point of care tests feasible are really optimal because it's a golden opportunity when you have your client, patient in the office there with you to be able to have same-day diagnosis and treatment. For diagnosis, it's important to consider history. For often syphilis, we need to understand history of treatment. And getting timely test results are important, but sometimes consultation is important too. Consulting with experts to confirm diagnosis. Preferably on-site, oral, and injectable options for treatment are available and are free or inexpensive. Management is important too, and I think it's important to close the loop. Track that treatment has occurred, follow-up testing, partner notification, and connect to HIV prevention strategies if that is of interest. So just an example, since syphilis I'm considering as the backbone, this could be considered a syphilis model where screening is done starting with either a non-treponemal or a treponemal test. I prefer the algorithm where non-treponemal tests precede treponemal tests, but there's different opinion. And preferably point-of-care testing so you can get the result right when the person is waiting. And then you can make the diagnosis there with history examination and consult if necessary, and provide treatment on the spot with on-site benzathine penicillin and or doxycycline, with the caveat that doxycycline be provided for those that can be compliant with therapy. But also management, ensuring treatments could be If it's on site, that's easy, but if you refer, it's important to follow-up testing date, partners contacted, and if HIV negative, PrEP. So to further the idea of a service delivery model for STI, I think there's several steps that need to happen. And part of it is routinizing STI screening with HIV testing, PrEP, and treatment as prevention. And considering models that work for the specific environment and population. I think we need training of providers in key populations and those that provide HIV prevention on an optimal STI service. I think we need to support same-day diagnosis and same-day treatment for optimal service delivery. It's not always feasible or possible, but it's optimal. And management and tracking. I think we need to mobilize stakeholders for resources to support STI screening as a part of HIV prevention and engage our community partners on the importance of STI service. So I just want to harken back to the fact that STIs are important and they do increase the risk of HIV transmission and acquisition. They're a very important part of the HIV prevention toolbox. A number of beneficial benefits of STI screening and treatment in the HIV prevention environment: reducing likelihood of HIV transmission and acquisition, improving engagement and care, and reinforcing prevention messaging, and connecting those that are negative to HIV prevention that really work, like PrEP. And then, of course, screening and treating partners. And I just want to thank the program. This is our HIV STD research program. And thank a number of people that have helped me think about this presentation.
Thank you very much.